Hello, dear students. Today our topic is pathophysiology of shock. Shock is one of the most dangerous situations which is associated with different influence. It could be external factors such as an incident or trauma. Sometimes it could be internal situation which is associated with cardiogenic shock or some inflammatory response. But sometimes it also could be connected with different influences associated with the doctors or nurses manipulation in case of anaphylactic shock. And as you understand, it's one of the most severe and most spread cause of mortality rate among the patient in intensive care unit. So you have to understand etiology, pathogenesis of shock. You have to be familiar with the mechanism of development of main complications of shock, such as DIC syndrome, acute respiratory distress syndrome, multiple organ dysfunction syndrome, etc. And one more thing, it doesn't matter which etiological factor leads to development of shock. You have to know that shock, such as in some other typical pathological processes, is the typical pathological process. So, in spite of the etiology factor, the rules and the principles and mechanisms of development of shock are the same. So, almost all neuroendocrine responses, almost all hemodynamic changes, and damage of inner organs in shock will be typical. So if you understand the concept of shock, if you understand the mechanism of its development, you will be more familiar with any kind of particular types of shock, such as a neurogenic, obstructive, or distributive shock. So let's talk about the definition of shock. But before this, let's stop into the agenda of today's lecture. So what we have to know. First of all, we have to tell about the definition, as I told before. Then we move to the classification and we'll discuss about the different types of classification and division of shock according to the etiological factor, according to pathogenesis, and according to the stages of development. Then we move to the clinical manifestation of shock and discuss about the mechanism of development of damage of inner organs, such as shock kidney, concept of shock lungs, shock intestine, etc. And we will stop into development of vicious circles, which could be different in shock. We will stop in the topics of complications of shock, such as DIC syndrome or multi-organic insufficiency. And then we have to move to investigation of pathogenetical mechanisms of different types of shock, because some specificity we can name depends on etiological factors. Most important mechanisms are the same, but some differences and details we will discuss. And then we are going to talk about the principles of pathogenetical treatment, support, and prognosis for the patients with shock. So let's start. Shock is a state of acute inadequacy of blood supply to the vital organs of the body, which finally leads to acute hypoxia or even anoxia. And when we discuss about the history of shock development, we have lots of information about the studies of shock. And first notes about shock, we can think that was associated with Hippocrates. And it was associated with different traumatic influence. Shock as a definition was firstly mentioned by French scientist and surgeon Ledrens, and it was in end of 18th century. And when we discuss about the spread of theories of shock, it started in at start of the beginning of the 20th century during the World War First, and then it spreads according to this traumatic influences, and lots of information was associated with traumatic shock, and the investigation of Pirogov's also play one of the keyest role in investigation of shock development. And since 70s years of previous century, we already have a current explanation and definition of shock, and we use classification of shock, which we still use today. What is shock? According to the old scientists, Samuel Gross tell about shock as an root unhinging of the machinery of life, and you have to understand that it's really truth, and patients with shock unfortunately undergo extra severe pathogenetical stimulus, and finally it leads to different pathogenetical mechanisms of development, which sometimes could have favorable prognosis, but unfortunately lots of patients can die from shock. If we are going to discuss about the epidemiology of shock, usually among all cases, one of the most spread is septic shock, about 60% of cases. And approximately 20% is cardiogenic shock, and also near 20% is hypovolemic shock. But when we discuss about the prognosis of the patient, it also depends on etiological factor, and we can tell that anaphylactic shock or neurogenic shock are readily treatable and respond to medical therapy compared to septic shock. In spite of situations that now we have lots of antibiotics, different effective antibiotics, unfortunately mortality rate for septic shock is between 30 and 80%. And one of the most dangerous kind of shock is cardiogenic shock, when mortality rate even higher, and in average mortality rate between 70 to 90%. So how could we classify it, and what can we tell about the shock? First of all, we have to classify it. Shock depends on etiological factors, and some of them we mentioned already. So Blalock classification includes next points. It divided shock into traumatic shock, hypovolemic shock, hemorrhagic, neurogenic, septic, anaphylactic, cardiogenic, burning, and reperfusion. When we see into this classification, it's only etiological factor in the basis. But if we are going to connect pathogenetical mechanisms and these trigger mechanisms for shock development, we move to the another one classification, which divide shock into hypovolemic, cardiogenic, and situation with low peripheral resistance states. So hypovolemic shock usually associates or with blood loss or volume loss, into outside, or sometimes it could be internal volume loss due to increase of vascular permeability and accumulation of fluid in peripheral tissue. Cardiogenic shock associates with primary damage of the myocardium or pericardium sometimes. So it usually caused by primary pump dysfunction or impaired inflow or outflow. And group of shocks which associates with low peripheral resistance, it's usually vasogenic shock, which caused by increase of releasing of biologically active substances such as an septic or anaphylactic shock, or sometimes it could be neurogenic shock, which caused by loss of sympathetic vascular tone and severe increase of total peripheral resistance, decrease of total peripheral resistance. So it gives us this pathogenetical classification of shock, which better describe underlying problem and divide the shock into hypovolemic, cardiogenic, and distributive shock. So let's see that key idea is disintegration of blood flow in shock. And this disintegration, in spite of etiological factor, finally leads to disorders of blood supply of peripheral tissue and leads disorders to the microcirculatory part. But it also associates with central mechanisms. And if we are going to discuss about these central mechanisms, I mean central which involves these vital important organs, it firstly associates with disorders and function in cardiovascular system, and it could be associated or with acute heart failure, or with decrease of venous return, or it could be associated with some things like redistribution of the fluid in our organism, and it usually could be or neurogenic or anaphylactic or septic situation. When we will discuss about the physiological principles of the regulation of tissue perfusion, it's usually associates with the cardiac output and total peripheral resistance. And all of these parameters could be disturbed in case of shock. So it could be influence of different etiological factor into the stroke volume. Sometimes it could be influence which involve the total peripheral resistance and sometimes heart rate, but it depends on etiological factors. Could be situation with involvement of all of these factors. In case of cardiogenic shock, we see this problem and we see activation of different compensatory mechanisms which try to support, but unfortunately they fall because we have a severe central problem with the heart contractility and cardiac output. When we are going to discuss about the different kind of shock, we have to tell about the one more situation which associates with obstruction, and we know this kind of shock as an obstructive shock. So is the form of shock associated with physical obstruction of the great vessels of or systemic circulation or pulmonary circulation, and several conditions can result in this form of shock. It could be cardiac tamponade or constrictive pericarditis, which finally leads to decrease of the heart contractility. It could be tension pneumothorax or pulmonary embolism. Sometimes it could be valvular disorders such as an aortic stenosis, which leads to obstruction of ventricular outflow tract. Also, it could be not only aortic but hypertrophic subaortic stenosis, which also influence the same way of pathogenesis. And sometimes we have to tell about abdominal compartment syndrome, which associates and could be caused by the sepsis or severe abdominal trauma, And finally, it also can lead to signs and symptoms of the shock. So when we will discuss about the pathogenetical mechanism of development of shock, as I told before, it is a typical pathological process. So in spite of etiological factor, we will see the same mechanisms of compensation and the same neurohumoral responses which caused by influence of etiological factor. So firstly, shock pathogenesis associates with inadequate systemic oxygen delivery, which activates response of sympathetic nervous system, which stimulates cortisol releasing and also can lead to activation of renin-angiotensin-aldosterone system. All of this kind of response has one and main idea is to protect and is to restore lost function. So first of all, activation of sympathetic nervous system gives us cardiovascular support because of positive inotropic influence, because of positive chronotropic influence, and because of increase and support of total peripheral resistance. So it gives us maintaining of cardiac output, maintaining of stroke volume, and maintaining of the total peripheral resistance. Together with activation of glucocorticosteroids and mineralocorticoids, which gives us increase of sodium reabsorption and water reabsorption, we will see increase of accumulation of fluid and support from the total blood volume point of view. And finally, it makes and it gives us some period of compensation after this severe influence of causative agent. But it depends, and you have to understand that it could be different situation with the development and with activation of stress limiting and stress protective system. So when we discuss about the shock as a complex of syndrome, the most important problem and why we see this such high mortality rate of the patient is the problem with decreased peripheral tissue perfusion and impaired cellular metabolism, which finally leads to imbalance between the supply and demand for oxygen and nutrients in peripheral tissue firstly, but then in vital important organs too. So we see this imbalance, and unfortunately this compensatory stage could be promoted to the some unfavorable stages, and we will tell a bit later about them. So if we are going to discuss about the sense of this sympathetic activation and benefits which we get from this. First of all, sympathetic activation gives us increased myocardial contractility and leads us vasoconstriction. But hope that from the pharmacology course you familiar with different kind of receptors, and you know that stimulation of while alpha adrenal receptors gives us vasoconstriction, and vessels with alpha adrenal receptors characterized by increase of vascular permeability, increase of vascular tone, but the vessels with beta adrenal receptors we will see vasodilation. And usually we have to tell that peripheral organs and tissue vessels became constricted and vital important organs became dilated. So we see increase of blood inflow to the vital important organs and decrease of blood supply of peripheral tissue. So it leads to firstly to redistribution of blood flow with an increase of the coronary blood flow, with increase of cerebral blood flow, but with peripheral circulatory hypoxia as in one of the keyest mechanism of development of the shock. When we will discuss about the another kind of the neuroendocrine responses, we have to tell that together with releasing of the catecholamines and glucocorticosteroids, we also will see release of pituitary hormones such as an ACTH and ADH. Also, we will see increase of cortisol and other antagonists of insulin, which gives us increase of blood glucose level, and it leads to increase of glycemia, which gives us some reserve for energy production. And it gives us again some period of the compensation, which together with this vascular tone and centralization of circulation helps to maintain blood supply of vital important organs such as in brain, such heart, lungs, and sometimes liver. And we know this phenomenon as a centralization of circulation. So all our forces, all blood moves to the vital important organs, and thanks to this we will see maintaining of the cardiac output, maintaining of stroke volume, and we will see continue of life. But this centralization of circulation is characterized by arterial vasoconstriction of different peripheral organs, and some of them less may be important now, I mean, in this situation, such as in skin, as an example. But sometimes this centralization could have negative influence because, as an example, we will see decrease of blood flow through the kidney, and it will manifestate with oliguria and anuria. And when we discuss about the prognosis for this activation of these neuroendocrine factors and mechanisms, you have to understand that for the short time period of time, it could be effective and it could characterized by maintaining of BP as an example. So decrease of BP, but maintaining of BP and maintaining of the oxygen supply of the brain and heart. But for the long period, these compensatory mechanisms are not effective and fails when shock state is prolonged. So when this etiological factor do not remove from the patient. And it finally leads to the familiar for you, hope that SCOM of the influence of circulatory hypoxia into the cells, into the peripheral tissue. All you know that this inadequate tissue perfusion can lead to decrease of oxygen supply, and it leads to shift from aerobic glucose oxidation to the anaerobic glycolysis. It will be characterized by decrease of energy production and accumulation of different waste products, and one of them is the lactic acid. It finally leads to decrease of energy production and lack of lots of cell function, such as an ions imbalance, activation of different phospholipases, activation of free radicals, and it can finally lead to damage of the cell and cellular membrane with hypoxia, and we know this as an hypoxic damage of cell. Unfortunately, it is very dramatic and spread in different tissue during shock, so we will see this global tissue hypoxia with severe endothelial disruption, with releasing of different waste products, and with unfavorable influence into in the organs includes brain, heart, and lungs. So if we make some pathogenetical scheme of development of this shock influence into the cells, we have to stop into key points, such as in this decrease systemic oxygen delivery finally leads to ATP depletion, and it's clear leads to dysfunction of ion pumps, and we will see accumulation of sodium inside the cell, and it can lead to cellular edema. Finally, it can lead to the hydrolysis of cellular membranes and cellular death. And it's clear that hypoxic damage of cells associates with the calcium influx, and it can lead to disorders and depression of mitochondrial activity. And we will see lysosomal rupture too, which finally leads to damage of the cells and tissues. And also, as you understand, that maintaining of the cerebral and cardiac perfusion, unfortunately characterized by shift and problems with splanchnic, musculoskeletal, and told already about the renal blood flow. So unfortunately, all these cellular responses cannot be compensated by functional system, and we see accumulation of lactic acid and this systemic metabolic acidosis that overcomes the body's compensatory mechanisms because of this lack of kidney function, which also became one of the keyest pathogenetical mechanism. As you understand, long-term presence of all this catastrophe in cardiovascular system, I mean in systemic circulation and in peripheral circulation, finally can lead to involvement and secondary damage of different vital important organ, and we have to tell about the complication or manifestations of shock, which includes development of multi-organ dysfunction syndrome or MODS, which characterized by involvement of the important organ into pathogenetical mechanism of development. And it's clear that heart suffer from this negative influence, respiratory system also with formation of acute respiratory distress syndrome. We will see pre-renal acute renal failure development. Sometimes can tell about DIC syndrome, and if we see involvement of more than one but 2 and 3 system into the process, pathological process, we have to tell about the multi-organic insufficiency, which result in end organ failure. And as you understand, this situation with the releasing and with formation of this vicious circle, I hope you see already that this vicious circle will be developed. We can tell about the different stages in pathogenesis of shock. So if we are going to discuss about the classification of shock and division into the stage, we have two main types of this classification. First of all, it's the classification of traumatic mostly shock, which divides shock into the two stage, erectile stage and torpid phase. So first is characterized by moving and speech excitation, characterized by releasing of catecholamines, renin-angiotensin-aldosterone system, but it spent usually 15 maybe to half an hour, 15 minutes to half an hour, and then if we have severe damage, patient with traumatic shock became more torpid, so more slow. We will see depression, slow cognitive activity, absence of reflexes, and finally it can lead to decompensation. And if we are going to another kind of classification of shock, like current classification, it divides shock into the three stage. And all types of shock, we have to tell about the three stage of development. So first of all is compensatory stage, which close to this erectile stage by Pirogov. Then we see progressive stage, and finally refractory stage or irreversible stage. And this progressive and irreversible is torpid phase by Pirogov. So we have some pathogenetical link, and this erectile and torpid mostly for traumatic, but for all types of shock there are three. Again, compensatory, progressive, and irreversible or refractory. And you have to understand this multi-organic or multi-organ dysfunction syndrome is usually manifestation of irreversible stage when we will see involvement of different organs and system. So you in clinical practice have to differentiate. Firstly, you have to understand that you have the patient with shock development, but it's clear this patient usually characterized by specific, non-specific, but very prominent clinically manifestations. What are the symptoms? So first of all, patients suffer from manifestation of hypoxia. So usually patient became pale. Usually this patient have tachypnea or dyspnea, and patient have tachycardia. So these symptoms associates with compensatory mechanisms which help to maintain more or less adequate blood gas composition. So we will see stimulation of respiratory center for increase of oxygen supply of blood and oxygen supply of inner organs, and we will see activation and increase of heart rate, which also gives us maintaining of the cardiac output. Also, as in clinically manifestation could be symptoms which associated with peripheral vasoconstriction, and it could be some weakened peripheral pulse and cool skin. Also, one of the most prominent symptoms of the shock is decrease of blood pressure. And we have to tell that usually we see vice versa decrease of systolic and diastolic blood pressure with increase of heart rate. When we discuss about the other symptoms of the patient with shock, is usually also could be associated with altered mental status, and also involvement of other system into the pathological process, such as decreased urine output. It could be some manifestations from the GIT. Sometimes it could be development of different secondary damage of GIT, such as stress ulcer development. Sometimes involvement of inner organs also gives us some other manifestations, such as dysrhythmias could be, or bradycardia. We will see decrease of saturation and falling of the partial pressure of oxygen in peripheral blood. And we can see finally loss of consciousness and death development. But all these symptoms could vary, depends on stage. So you have to understand that this erectile or compensatory stage will be characterized by activation of compensatory mechanisms which are act more or less effectively and which is maintain BP and which is maintain of the coronary blood flow in near normal level, and it gives us low level of clinical manifestation. So we will see maintaining of the blood pressure and tachycardia in this for this patient. When we discuss about the compensatory stage, it could be some paleness, sometimes it could be decrease of the urine output, maybe some other things. But again, when we discuss about the compensatory stage, not so fatal clinical manifestations for this patient. Compared to the next stage, when we see already negative influence of the shock into the inner organs, and in progressive stage we already see manifestation of hypoxia, and these manifestations became prominent. So we see development of the metabolic acidosis and decrease of energy production, which leads to suppression of the myocardial function. So patient can suffer from arrhythmia, suffer from dysrhythmia. Already this patient can suffer from endothelial damage, and it associated with releasing of different biologically active substances, some prostaglandins, leukotrienes, free radicals, singlet oxygen, and hydrogen ion. And it can finally lead to this disbalance and disorganization of microcirculation. Unfortunately, in progressive stage, one of the most negative pathogenetical mechanism could be higher tendency to development of the DIC syndrome, which associates with this increase of vascular permeability and endothelial damage, which leads to sluggish of blood flow and increase of viscosity of blood, with damage of the tissue, with releasing of tissue factor, which can lead to development of DIC syndrome development. And when we discuss about the irreversible stage, unfortunately, all these compensatory mechanisms are exhausted, and we see already hypotension, so fall of BP, systolic blood pressure could be 40, diastolic blood pressure could be even 0, so severe hypotension, could be movement from tachycardia to bradycardia, or tachycardia but it is not efficient, and finally it's characterized by myocardial depression, fall of cardiac output, fall of stroke volume, and multiorganic insufficiency when we see a decrease of saturation, decrease of partial pressure of oxygen, increase of partial pressure of carbon dioxide, anuria, and finally circulatory and respiratory failure. And it's clear that for this kind of patient, unfortunately, we have an unfavorable prognosis. And if we are going to make some pathogenetical scheme of development of the compensatory stage, progressive stage, and irreversible stage, we have some markers for each stage. So if we discuss about the compensatory, we see increase of heart rate, maintaining of BP, tachycardia and tachypnea, but already reduced urinary output and some changes in the skin, but it depends. So mostly we see vasoconstriction and cool and pale skin, but sometimes in situation with septic shock could be warm and dry skin because of releasing of different vasogenic amines, biogenic amines, and because of vasodilation. If we are going to discuss about the progressive stage, we already see manifestation of tissue hypoxia, and it will characterized by presence of the acidosis in blood, and we have to analyze blood gas composition, and it gives us the information about the metabolic acidosis firstly, but then it could be combined damage, metabolic acidosis and respiratory acidosis too, because of involvement of different in the organs such as in kidney and what is the most dangerous, respiratory system. So patient can became suffer from hypotension already, usually narrowed pulse pressure which associated with reduced stroke volume, weak and rapid pulse which associates with decrease of cardiac output, could be shallow respiration, still cold skin, and this paleness moved to the cyanosis. So we will see progression of hypoxia and patient became cyanotic. And then if this progressive stage move into the another one, into irreversible stage or refractory stage, we have to tell about the negative influence into the cardiomyocytes. So we can see different arrhythmias, a rapid fall of BP, and we cannot support of this blood pressure, unfortunately, even with restoration of the fluid. Then patient became unconscious, and we see group of abnormalities. It will be still acid-base abnormalities and also electrolyte disorders. We can see the different pathological respiration for this patient, kind of chain stocks as an example respiration, and anuria because of development of acute renal failure, pre-renal type. Unfortunately, when we discuss about this irreversible or refractory stage, in spite of our manipulation, in spite of giving fluid to the patient, in spite of different anti-inflammatory drugs administration, we see irreversible damage of cells and tissues, and we will see depletion of energy stores, and we will see accumulation of different waste products, which finally leads to the damage and to death of the patient. And as you understand, here in pathogenesis of shock, we have to tell about the vicious circle development. And if you remember our first classes of the pathophysiology, one of the most important thing for future doctor is to think and to remember about possible vicious circle development of the patient, and try to predict development of next steps and interrupt possible development of vicious circle. So let's create few vicious circle for patient with shock. First of all, first kind of vicious circle could be associated with decrease of total blood volume because of the vascular damage, vasodilation, and situation with hypovolemia also result in more severe hypovolemia because of loss of fluid into the peripheral tissue, into the interstitium space. Another kind of vicious circle could be associated with oxygen deficiency and acidosis, which leads to damage of myocardium. So decrease of blood pressure in spite of first etiological factor associated with severe decrease of BP because of loss of the contractility and inefficient cardiac function, heart function. One of the common kind of vicious circle which we see among the patient associates with DIC syndrome development. So in spite of, again, etiological factor, in DIC we will see different stage. We will tell a bit later about that. And unfortunately, hypocoagulation, which we see in progression of disseminated intravascular coagulation syndrome, leads to blood loss, and it also gives to severe hypovolemia for this patient. So let's see how many types could be, and your task is to think about the next steps and try to prevent each of them, because you have to understand that all these types of vicious circle could be possible in one patient. So all of this damage and all of this um, prognosis could be in one patient. And as you understand that these problems with mechanisms of development of shock leads to involvement of inner organs, and we have to stop into main complication and have to tell about the concept of shock organs. So what organs mostly involved in severe shock? Usually five major complications. Is development of shock lungs or acute respiratory distress syndrome, involvement of kidney, and we know this is a shock kidney, and development of acute renal failure. Damage of gastrointestinal tract, usually both stomach and intestine, and gastrointestinal ulceration, and DIC and MODS when we discuss about the next two. And when we have to tell about the complications of shock and prognosis for the patient, you have to understand that involvement of one one system of organ leads to worse prognosis. But when we tell about the two or even three organs of system, a system of organs involvement, it gives us unfavorable prognosis for the patient and more than 80% of mortality rate. So your task, together with the prevention and think about the possible development of vicious circle, is to make strong monitoring of different organs such as lungs, kidney, GIT, and hemostasis to prevent and to predict development of multi-organic insufficiency, because it gives your patient better prognosis. And let's make some stops in pathogenesis of each of these complications, and let's start from acute respiratory distress syndrome. So, is potentially lethal form of respiratory failure that can follow severe shock. And we familiar with acute respiratory distress syndrome associates with inflammation, associates with some infectious disease like COVID-19. And important mechanism of development of distress syndrome is activation and releasing of biologically active substances. So most important thing is damage of endothelium and releasing of different biologically active substances. And it finally leads to damage of lung parenchyma. It can leads to disorders in production and composition of surfactant, which finally leads to lack of dysfunction of surfactant, and it can lead to atelectasis, which finally leads to development of respiratory failure. So from one point of view we see edema formation, from another one we see atelectasis, and together with accumulation of different pro-inflammatory cytokines and pro-inflammatory mediators, it leads to lack of respiratory function, and it gives us already mixed hypoxia. If in shock we started usually with circulatory hypoxia, but then with involvement of respiratory system we see already mixed hypoxia, circulatory and respiratory, and you understand that prognosis became worse. Then next system, but usually is the first system which involved, is renal failure, and we see usually acute renal failure development and oliguria, one of the prominent symptoms of shock development because of higher level of susceptibility of tubules to ischemia. And sometimes, as an additional factor which leads to renal failure, could be accumulation and negative influence of toxic products like myoglobin in reperfusion syndrome or in tourniquet shock, which also can gives us additional negative influence into the renal function. And renal failure, unfortunately, negatively influence into the prognosis of the patient too, such as an acute lung failure, respiratory failure, because we have lack of kidney function, we have an azotemia or even uremia, and we see an effective compensation for acid-base balance and unfortunately negative prognosis for the patient. Usually patients with shock also suffer from ulceration, and unfortunately it can give us increase some problems with BP because of bleeding if we see this ulceration of the stomach. And one more thing is increased permeability of the gastrointestinal mucosa for intestinal bacteria, and it can also gives us more inflammatory response, accumulation of different biologically active substances, and also higher tendency and susceptibility to a development of systemic inflammatory response syndrome or SIRS. And one more important thing which we have to tell about is DIC syndrome. And here I can show you the interesting video which help to revise your knowledge about disseminated intravascular coagulation, which we discussed already in topic of hemostasis. So let's see the video about DIC syndrome.
Disseminated intravascular coagulation, or DIC, describes a situation in which the process of hemostasis, which is when, after blood vessel wall injury, liquid blood rapidly becomes a gel, called coagulation or clotting, starts to run out of control. When this happens, lots and lots of blood clots start to form in blood vessels serving various organs, leading to organ ischemia. DIC, though, is also called consumption coagulopathy, because all this clotting consumes platelets and clotting factors. Without enough platelets circulating in the blood, other parts of the body start to bleed, with even the slightest damage to the blood vessel walls. So paradoxically, patients have too much and too little clotting. Normally, after a cut and damage to the endothelium, or the inner lining of blood vessel walls, there's an immediate vasoconstriction or narrowing of the blood vessel, which limits the amount of blood flow. After that, some platelets adhere to the damaged vessel wall and become activated, and then recruit additional platelets to form a plug. The formation of the platelet plug is called primary hemostasis. After that, the coagulation cascade is activated. First off, in the blood, there's a set of clotting factors, most of which are proteins synthesized by the liver, and usually these are inactive and just floating around in the blood. The coagulation cascade starts when one of these proteins gets proteolytically cleaved. This active protein then proteolytically cleaves and activates the next clotting factor, and so on. This cascade has a huge degree of amplification and takes only a few minutes from injury to clot formation. The final step is activation of the protein fibrinogen to fibrin, which deposits and polymerizes to form a mesh around the platelets. So these steps leading up to fibrin reinforcement of the platelet plug make up the process called secondary hemostasis and results in a hard clot at the site of the injury. Now, as soon as that clot's formed, the body's also initiating pathways to break down the clot so that it doesn't get bigger than it needs to be and dissolves when it's not needed anymore, a process called fibrinolysis. And this process produces fibrin degradation products. Normally, the formation of new clots and the process of fibrinolysis are in a steady balance. Now, in serious medical conditions, like for example sepsis, malignancy, serious trauma, obstetric complications, or intravascular hemolysis, like you might see with blood type incompatibility, there can be a release of a procoagulant that tips the scales in favor of clot formation. Procoagulants could be proteins, like tissue factor, or bacterial components, like lipopolysaccharide. Or it could even be the presence of enzymes that help to proteolytically cleave and activate clotting factors. Whatever the cause is, in response, the coagulation pathway goes into overdrive, resulting in widespread clot formation, which plugs up medium and small blood vessels, which leads to ischemia, necrosis, and eventually organ damage. The kidneys, liver, lungs, and brain are particularly susceptible. The massive formation of clots throughout the body depletes the supply of platelets and clotting factors. To make things worse, as those clots are broken down through fibrinolysis, fibrin degradation products are released into the circulation, and these interfere with platelet aggregation and clot formation, making hemostasis even more difficult. And the result is this paradox, right? On one side, you have thrombosis, which is when clots obstruct the vessel. And at the same time, you have trouble forming new clots, which leads to bleeding. Laboratory findings in disseminated intravascular coagulation include decreased platelets and decreased fibrinogen. There's also a prolonged prothrombin time, or PT, as well as prolonged partial thromboplastin time, or PTT, both of which reflect having lower levels of circulating coagulation factors. In addition to lower levels of specific clotting factors, there are elevated levels of D-dimer, which is a fibrin degradation product that's produced when fibrin clots are broken down. Now, it's worth mentioning that in some cases, disseminated intravascular coagulation can be a more chronic process, like in individuals with certain solid tumors and large aortic aneurysms. And in those situations, there might be physiologic compensation, which makes the lab results look relatively normal. In either acute or chronic DIC, the treatment focuses on treating the underlying cause, because that's what drives the activation of the coagulation cascade. In addition, the goals are to support the various organs, using measures like ventilator support, hemodynamic support, and transfusions if they're needed. Alright, as a quick recap, DIC happens when the balance between forming new clots and breaking down clots is tipped in favor of clots, which leads to widespread clotting and organ ischemia, while at the same time depletes clotting factors, paradoxically leading to bleeding. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
As you understand, DIC syndrome is one of the most dangerous complications of shock. And DIC syndrome is paradox in hemostatic sequence, which is characterized by widespread coagulation and bleeding in the vascular compartment. And if we try to help the patient, we have to be ready to make diagnosis of DIC and possible development of DIC in time, because only in early stage, in first stage of development of DIC syndrome, we can help to the patient and can prevent development of cascade of pathogenesis, and it can lead to survive of the patient life. So the main problem with DIC is again the formation of vicious circle, and main task for you is to predict, predispose, and make administration in time and care in time. So I think that now we can stop in pathogenetical mechanism discussion for the typical pathological process shock and move and tell few points and key sentences about the different types of shock because we have some specificity depends on etiological factor, and we have to start from the first neurogenic shock. So what is it? Usually this type of shock is characterized by loss of sympathetic vasoconstrictor tone in the vascular smooth muscle, and it finally leads to widespread arterial and venous vasodilation because of reduced anatomous function, because of reduced sympathetic activity. Um, because of development of neurogenic shock, we see a decrease of venous return and drop in cardiac output, which finally result in hypotension. As an etiological factor for neurogenic shock, the most spread is the spinal cord injury. Then etiology could be associated with influence of some medications or spinal anesthesia. Sometimes a neurogenic shock could be caused by vasomotor center depression, severe pain, or some endocrinopathy or problem with blood glucose level, usually hypoglycemia. When we will discuss about the pathogenesis of neurogenic shock, usually first hemodynamic phenomenon occur within 30 minutes of spinal cord injury at the fifth thoracic vertebra or above, and can last up to 6 weeks. Can be in response to spinal anesthesia, and the result, as you understand, is the problem with vascular tone. When we come to the pathogenetical scheme of development of neurogenic shock, most important is development of vicious circle because of development of circulatory hypoxia, accumulation of different waste products, and their secondary influence into the vascular wall, and it leads to vascular paralysis, which firstly was caused by the neurogenic factor, but then metabolic factor secondary negatively influence vascular tone, and we see development of progressive stage and finally irreversible stage. If we are going to discuss about the clinical manifestation of neurogenic shock and its some specificity, usually we see the same manifestation as in another types of shock, such as in hypotension, such as in dry skin, but as in specific for neurogenic could be bradycardia because of lack of sympathetic activity. Sometimes as a manifestation could be temperature dysregulation resulting in heat loss, and even poikilothermia for the patient when it takes the temperature of the environment, compared to another kind of shock when we do not see such kind of symptoms. And when we discuss about the prognosis of neurogenic shock, it depends on degree of damage of the spinal cord injury, if it is an etiological factor, or it depends on in time administration of the treatment, which can support cardiovascular system, which can support vascular tone, restore total peripheral resistance, and if we help to the patient in time and use both etiotropic and pathogenetical treatment, we can tell about the more or less favorable prognosis for this kind of patient. Compared to the next one type, next we have to tell about the septic shock. As I told before, you remember that it's one of the more dangerous type of shock with high mortality rate, and it is the most common type of shock in current time. So patients usually suffer from different infections with some resistance to antibacterial treatment, with overwhelming of infections, higher tendency to development of systemic inflammatory response syndrome, and all of these types of the problem can lead to development of septic shock and could be dangerous. And I think that it makes sense to start investigation of pathogenesis of septic shock from the phase of shock. So let's see the small but informative video about the patients who suffered from septic shock. Let's see.
My mother, a 20-year breast cancer survivor, she dies of a disease that we never even heard of.
Septic shock, sepsis, and she was like, how do you spell it? I said, I don't know.
Really, does it affect that many people? Then why haven't I heard of it?
My mother, Mama, she had plans of being a gospel singer.
One glorious happy day.
They found a clot in her femoral artery. She got through that surgery, but she started complaining of a lot of weakness, couldn't catch her breath. When I heard the word sepsis, I didn't understand it.
I remember that I went to bed, woke up to find the EMTs in my room. My doctor friend called the hospital and said, look, unless somebody's coding, there's no one in there as sick as this man is right now. Get a doctor in there. In the next few hours, I had one shutdown after another, all of my organs, lungs, kidneys, eventually a heart attack. My toes were blackened and gangrenous. It was very unclear as to whether I would survive.
It was Halloween. He was up and crying and crying. I took his temperature, 102.3, and his color was gray. His lips, his everything was gray, and he was not responding. We got to the hospital. He got swelled up, so he was huge. And one of the doctors said, we don't know if you'll be able to take him home. I'd been waiting for him for all these months, and I've only had him 3 weeks. He's mine. I wish I would have asked more, but I felt like I was supposed to know as a mother.
I didn't understand that any infection could result in a toxic response that is known as sepsis. It started when I went to the dentist and had some dental work. Following that, I developed an infection. And then septic shock.
I can't even describe to you the horror of seeing her die of sepsis. The body swelling up twice its size, fingers turning black, having to be intubated. It looked like someone took a shotgun and shot her in the leg. That's what it looked like.
For me, this could have a very different ending. And it's why I share my survivor story.
And the nurse, her name was Annie, and she says, are you ready to hold him? And I said, oh my God, yes. She put him in my arms. And she says, he's gonna be okay. I thought maybe if I share my story, somebody will learn from it.
Mama's gone, but maybe somebody else can be saved.
So you understand that different age of patient, different phone of their health, different causative agent, and unfortunately, very often unfavorable prognosis for the patient with septic shock. So let's discuss and let's make more clear what is the difference between such kind of state: sepsis, severe sepsis, and septic shock, because it's all of them are very severe and dangerous, but we have some specificity. So what is this sepsis? It's a group of symptoms or clinical syndrome which complicates severe infections and represents with systemic response to the infections. So very close to the definition of systemic inflammatory response syndrome. When we have a situation with organ dysfunction, so with secondary damage of the inner organs because of this severe inflammation, we have to tell about severe sepsis, and usually this patient can suffer from overwhelming of infections and some involvement of cardiovascular system, respiratory system, GIT, kidney with pathological process. So interaction between systemic inflammatory response syndrome, SIRS, and MODS. And the most prominent and the most dangerous manifestations of the sepsis and severe sepsis is development of septic shock situation when patient became suffer from hypotension. So again, we have to tell about systemic circulatory hypoxia and with severe fall of BP. And here in sepsis, it's very difficult to maintain of this BP, and even fluid resuscitation, unfortunately, ineffective. So despite the fluid resuscitation, we have a hypotension and presence of tissue perfusion abnormalities, damage of the vascular endothelium, and development of systemic inflammation. When we discuss about the etiological factors of septic shock, we have to tell that mostly it associates with the gram-negative bacteria, but sometimes even endotoxin can stimulate the severe inflammatory response and can lead to development of septic shock. But sometimes, as an etiological factors, could be some non-common causes, such as an gram-positive bacteria or even viruses, and we have to tell about the some severe inflammation again in COVID-19, the current pandemic etiological factor. Sometimes septic shock could be associated with parasites, protozoa, rickettsia, fungi, and mycobacteria even. In pathogenesis of septic shock, we have to tell that one of the most important thing is the releasing of lots of inflammatory mediators. It could be different types of mediators. Usually it's the prostaglandins, leukotriene, lots of cytokines, and we have to tell about the cytokine storm even. Free radicals of oxygen, nitric oxide, different biogenic amines, and all of cocktail of these biologically active substances, both premature and newly formed, or primary and secondary, associated with the etiological factor or associated with secondary alteration. All of these inflammatory factors influence vascular endothelium, and it leads to development of malignant intravascular inflammation. Usually it is uncontrolled, unregulated, self-sustaining, and unfortunately it is completely different from the normal inflammatory response when we have to tell about the protective mechanism. So here we see not protective but destructive influence from pro-inflammatory mediators. And the problem associates usually with this balance between pro and anti-inflammatory mediators. What are the trigger for this aggressive inflammatory response? Firstly, is the bacteremia or endotoxinemia, so severe infections, when we see prevalence and severe division of bacteria or high level of endotoxin in, in blood. Then, as a risk factor of development of sepsis, we can name a presence of huge areas of damaged tissue. So it's usually extensive surgery, real laparotomy is an example, some severe trauma, usually abdominal, or some other localization with limb trauma. And also one of the keyest trigger is the prolonged episodes of hypoperfusion. So we see that patient with septic shock suffer from accumulation and releasing and influence of pro-inflammatory mediators, firstly associated with the primary area of infections or primary foci, but from another point of view, we see aggravation of pro-inflammatory influences caused by hypoxia, caused by these circulatory changes. And finally, it leads to systemic activation of pro-inflammatory cells and releasing of potential damaging mediators. And one of the most susceptible factor which suffer from such aggressive influence is vascular endothelium. And let's see what are the main mechanisms and the main problems with endothelium in sepsis. You understand now how severe this damage of endothelium and how dramatic could be consequences. So let's make some logical scheme of the development of all these episodes. You have to understand that firstly we will see releasing of endotoxin from bacteria, and it leads to releasing of cytokines and cytokine storm. One of the most important is interleukin 6, but also tumor necrosis factor alpha participate in this response. Finally, these mediators stimulate releasing of own mediators, secondary mediators such as an arachidonic products, prostaglandins and leukotrienes, thromboxane A2. We see activation of kallikrein-kinin system with releasing of bradykinin. We see platelet activating factor releasing and activation of components, and finally activation of all complement system. These consequences are vasodilation, increase of vascular permeability, and decrease of systemic vascular resistance, so loss of total peripheral resistance, which leads to this long-term vascular insufficiency. Unfortunately, influence of these pro-inflammatory mediators spread into inner organs, and firstly it can depress the myocardial function, which gives this vascular insufficiency cardiovascular character. And we see in the patient with septic shock very spread dissemination of mediators, which became and which leads to damage of the peripheral tissue. So it leads to the widespread tissue damage, and unfortunately this overwhelming of infections usually followed by a period of immune suppression, increased risk of development of the secondary infections. What are the most harmful effects of mediators which leads to damage of inner organs? First of all, it could be damage of the cellular membrane, and it's very close, according to the mechanism, to hypoxic damage of the cellular membrane. But also, we can see impaired mitochondrial respiration, DNA strand breakage. Sometimes it could be apoptosis, with together with necrosis contribute to damage of the inner organs. Also, we will see immune hyporesponsiveness and coagulation disorders. Making picture, or I mean full picture of pathogenesis of the septic shock, we see that tissue hypoperfusion associate in patient with the sepsis with disbalance in demand and in ability to supply, because this invasion of the microorganism gives us situation with increase of metabolic activity or hypermetabolic state. Finally, this vicious circle result in impaired tissue metabolism, impaired cellular metabolism, and can lead to the progression and irreversible stage for the patient. If we make this scheme a bit simple, if we simplify this picture, we can draw such kind of vicious circle of the patient with the sepsis. We see the inflammatory mediators accumulation, which finally leads to microvascular circulation damage, and we saw this in video, which leads to hypoperfusion, cellular injury, and next step and next point of accumulation of inflammatory mediators, which finally leads to progression. Clinically, manifestation of septic shock from one point of view typical, but we have some problems with patient with sepsis, because sometimes we can lose this point when severe sepsis progresses into the septic shock. So what important in clinically manifestation of septic shock? First of all is the changes in coagulation, and we see increase of coagulation and decrease in fibrinolysis. So patient can suffer from manifestation of DIC syndrome with formation of microthrombi and with obstruction of the microvasculature. And also this could be hyperdynamic state with increase of the cardiac output, but for the short period of time. Also, patients suffer from tachypnea, as usually, with decrease of urine output, with GIT dysfunction, and temperature regulation and respiratory failure, which is common for the patient with septic shock. And when we discuss about the septic shock, we have to stop into the point of SIRS and CARS. So I few times today already mentioned about this definition. So what is it? In septic shock, we usually see the patient with systemic inflammatory response syndrome, when we see spread of these pro-inflammatory mediators, and which can leads to very fast development of multi-organic insufficiency. As an etiological factor for SIRS could be different inflammatory processes. Sometimes it could be acute pancreatitis or autoimmune disorders, some surgery or burns, and sepsis as in the main causative agent. In SIRS, we have non-specific clinical manifestation and non-specific parameters of its development. So, not strong markers for SIRS. Usually, it's very low or very high body temperature, low or very high WBCs amounts, so or leukopenia or leukocytosis with increase of amount of immature form with shift to the left, but sometimes it even could be leukemoid reaction with development of hyper leukocytosis. It changes in partial pressure of the carbon dioxide in arterial blood, and it also associates with changes of heart rate, or tachycardia or bradycardia could be even. So lots of discussion now about this clinical diagnosis and criteria of SIRS. But the most important thing you have to understand in pathogenesis of SIRS, we have some favorable phone for development of the septic shock because of dysregulation in compensatory anti-inflammatory response and pro-inflammatory. And here, if we see prevalence of systemic inflammatory, patient may suffer from massive inflammation, hypotension, and unfavorable prognosis with a refractory stage of this shock development. But sometimes we have another things. Is also could be situation with overwhelming infectious and multi-organic insufficiency, but because of persistency or recurrency of the different infections. And if again we will draw vicious circle for the patient of sepsis and septic shock, let's see that SIRS in together with hypoxia, one of the core problem for the development and one of the core of pathogenesis of septic shock. So what we have to do for the patient, and how can we help to the patient with severe infections? First of all, we have to protect inner organs. We have to use not mono but poly chemotherapy. I mean lots of the current antibiotics, and we have to use it intravenous injection. We have to suppress of the overwhelming of pro-inflammatory mediators with glucocorticosteroids. We have to make support for the cardiovascular system and respiratory support. And only complex of all this care management activity help to patient to prevent development of this damage of the endothelium and can prevent development of hypotension and shock. And very close to this kind of shock, I mean according to the pathogenetical mechanism, is anaphylactic shock, when we also see a problem with redistribution, problem with total peripheral resistance, and loss of fluid into the interstitium because of damage of endothelium. So you're familiar already with etiological factors. It's usually type 1 of allergy, and lots of risk factors which gives you opinion about possible and tendency to development of anaphylaxis among your patients. So, risk factor for fatal anaphylaxis has the patient with previous anaphylaxis and with some problems with control of asthma. As an etiological factors, let's see that it could be food and insects, but in first place we have to put antibiotics. So development of anaphylactic shock is strongly associated with the administration of the some treatment or with dental care. And when we discuss about the reoccurrence rate, it could be associated with insects, but also is the radiocontrast agent and again antibiotics. When we will name this kind of the drugs which can leads to development of anaphylactic shock, we have to mention about the non-steroidal anti-inflammatory drugs, about the trimethoprim, vancomycin, and penicillin or some related antibiotics. And again, remember about the possible anaphylaxis because of some injection of radio contrast agent. Pathogenesis of anaphylactic shock strongly associated with releasing of histamine and with releasing of the secondary mediators such as leukotrienes because of re-exposure of the allergen and with massive degranulation of mast cells with releasing of biologically active substances. And you remember about the anaphylactic shock that we have an three stage, but usually we see the patient already in clinical stage and pathophysiological stage when patient already suffer from severe hypotension. Sometimes it could be bronchoconstriction, and patients suffer from increase of vascular permeability and some manifestation from the skin or mucous membrane, but sometimes patient can suffer from additional symptoms such as an urticaria, could be stridor, chest pain sometimes, and as a common sign, patients suffer from swelling of lips and tongue and angioedema. If we discuss about the pathogenesis of the anaphylactic shock, important thing is this binding of Ig antibodies or cross-linked Ig receptors triggering releasing of powerful chemical mediators. And we have to remember about histamine and its influence. But not only histamine leads to development of anaphylactic shock. It's complex of mediators such as leukotriene, leukotriene E4, C4, and D4. It also releasing of thromboxane sometimes. It group of components of complement system such as an C3A and C5A as an act as an anaphylatoxins. And all of them mediators together with plasma mediators such as kinase system leads finally to the common effect and common influence into the endothelium. And we see finally vascular collapse, increase of vascular permeability, fall of peripheral resistance, and plasma leakage into the extravascular tissues. According to the all principles of pathogenesis, it leads to loss of blood volume, hypotension, and cardiac dysfunction. Additional bronchospasm and laryngeal edema can make worse the clinical manifestations, became patients suffer from circulatory and already respiratory hypoxia because of disorders and problems with ventilation, which provoke the early development of vicious circle for such kind of patient. But as we discussed at the beginning of the lecture, it's one of the favorable for the treatment kind of shock. So again, in time administration of glucocorticosteroids, in time administration of epinephrine and norepinephrine for the patient gives us favorable prognosis. So we have treat this kind of patient. But we have to think, remember about the possible risk factor and about the mechanisms of development of anaphylactic shock. It helps to save the life of our patients. And let's move to the one more, and to my opinion, the most dramatic kind of the shock is cardiogenic shock. The main problem is to very difficult to treat such kind of patient, and mortality rate could be even 90% of all kind of the cardiogenic shock development. Lots of patient and unfortunately very few favorable history, and one of this history I will show you in the next few minutes. Let's see.
The ranch is something that's been a part of Jennifer's life since the day she was born.
It's a place we come to relax. It's a place we come to have fun. We're just happy here. On July 5th, I had Calvin. He was our second little boy, and Cooper was so excited to be a big brother. It was such a sweet little time for us. And Stephen was working quite a bit, so we decided to come to the ranch to get some help, to get some more sleep. And that's when it happened.
I was just about asleep, and Jennifer came in the room and she says, "Donna, I think I'm having a heart attack."
And being the doctor mom, I ran into the bathroom to see what the problem was.
I was hot, I was vomiting.
At this point, I decided that we probably needed to go to the hospital.
I said, I can't go. I can't leave them without a mama. There was a lot of confusion. I wasn't quite sure what was going on.
We were driving towards Waco, and I kept telling her, "Jennifer, just stay awake with me. You know, don't close your eyes." And then all of a sudden, I looked over, and she started going into convulsions. I immediately started doing CPR on her. I was beating on her chest. In between all that, I was on the phone calling 911.
Once we got her in the truck, she was technically dead. We did 3 rounds of shock and CPR in between that, and after 3 times, she finally got a pulse back and began to stabilize for us.
I'm standing on the side of the road, and I'm thinking, this absolutely cannot be happening. She's 32 years old.
Once they got a faint heartbeat, then they decided to take me to Hillcrest in Waco. They quickly evaluated my condition and decided that there really wasn't a whole lot that they could do. They finally said, I know a place. I know of these physicians that can help her.
The foreign cardiologist in Waco, he had called me in a little bit of a panic. He had this young lady who had gone into what we call cardiogenic shock.
We sat down and we said, okay, we can't hurt her more than she's hurting already. The hospital has maximized what they can do. We're losing her very quickly. There's a small window of opportunity. She may make it here.
That's when he made the life-saving decision to send me to Memorial Hermann Heart and Vascular Institute.
There was no doubt she was getting in that helicopter, and she was taking off, and we were doing everything we could to save her life.
This transport of a patient this sick is a very dangerous proposition because things can go wrong while you're transporting. That's why we have very good life flight capabilities to get patients under extreme situations with good care and bring them safely here.
So when we got to Houston, I was immediately taken to the cath lab.
This is where our center really provides all the therapy for this severe refractory cardiogenic shock.
The MRI of the heart showed that she had actually had a heart attack on part of the front wall of her heart.
That is not very common. I mean, that is, most of 32 years old are very healthy.
We got her on the pump, and then we gave her some time.
And over the next few days, gradually tapered the medicines down and looked for signs of the heart to recover, and miraculously, the heart started recovering.
You know you have your family to support you, but it's just amazing when you see the outpouring of support that we had.
It's a very complex thing. It looks like one patient, but there are almost 40 people involved in caring for this patient. You need to have a very integrated approach. The left hand has to know what the right hand is doing and anticipate each other's moves.
If there was ever a day where everybody did the right thing, it was that day. So many hands that went over me, and it was amazing. That's why I'm here. As I got stronger and I was able to do more things, Cooper and I went outside and we were gonna fly his first kite. I just remember looking at him and just thinking, this is a mama moment that I almost didn't have.
Our family is back together. We're thriving, we're happy. Jennifer is doing things that when she was in the hospital, they told us she might not ever do again. I wake up every day thankful that we have another day, that I have my wife there, my two boys, we have our family together. And of course, she's able to hold her two little boys.
That's what makes it worth coming in at 3 in the morning, 4 in the morning, or sometimes sacrificing something that may be important to you to see somebody else get an opportunity to live a full life. That's really special.
Those kind of physicians, as Dr. Carr and Dr. Leoka, exceptionally great and excellent experts in their field.
What do you say to the person that saves your life? He gave me back my opportunity to be a mama and to give me a future and to raise my boys. Just getting to experience life and live my life. And I'm so grateful.
So from one point of view, rare situation with the favorable outcome, and I'm very happy for the hero of this movie. But from another point of view, rare situation with the age of this lady, because you understand that one of the most prominent etiological factors is myocardial infarction or some rupture of left ventricular aneurysm, and unfortunately is the usually more senile patient with the less favorable prognosis. So what are the etiological factors for the cardiogenic shock? Is usually myocardial contusion could be, sometimes acute myocarditis, dysrhythmia is a common one, or sometimes it could be end-stage cardiomyopathy, and here we have to tell about completely unfavorable prognosis, and only in time heart transplantation could help to this patient. But sometimes cardiogenic shock could be associated not with the loss of contractility, but with mechanical impairment of blood flow, and here it could be some valvular disorders, aortic dissection, pericardial tamponade, or some other things. So it's obstructive causes, and we already discussed about that. In pathogenetical point of view of development of the cardiogenic shock, most important thing is the situation that left ventricle cannot maintain adequate cardiac output, and activation of compensatory mechanisms unfortunately cannot be efficient, and all mechanisms of compensation such as in stimulation of inotropic influences, sodium and water retention, or vasoconstriction, all these mechanisms increase myocardial load into myocardium and increase the oxygen consumption, which reduces the heart's ability to pump blood, especially if patient has some myocardial ischemia, and consequently blood backs up, resulting in pulmonary edema. Eventually cardiac output falls and multiorganic organ dysfunction syndrome develops as the compensatory mechanism fail to maintain perfusion and patient die. When we discuss about the symptoms, all of them associates with the etiological factor, and one of the important is the changes in ECG, increase in myocardial oxygen consumption, some pain, and increase in pulmonary artery wedge pressure, and additional symptoms from the respiratory system and the kidney system. Few words I have to tell about the hypovolemic shock, because you understand that if primary cause is the loss of fluid in spite an etiological factor, it could be loss of from GIT, vascular, reproductive tract because of some malignancies, metrorrhagia or placenta previa, fluid loss, and we see some reduction in preload and a drop in stroke volume, which finally leads to this disorders in perfusion. In hypovolemic shock, we have to differentiate few stages or few classes. Depends on percent of fluid which is lost, and could be different prognosis. You understand that if it's a loss of 15% of the total blood volume or 40% of total blood volume. In care and in pathogenesis, most important is decrease of total blood volume, and in time resuscitation of fluid can help to prevent of development of progressive state and irreversible state. So clinically manifestation usually associates with the blood loss or fluid loss. All of this clinical manifestation very typical for any kind of shock. And when we discuss about the prognosis, everything depends on etiological factor and our ability to stop of influence of etiological factor into the patient. Do not stop into the obstructive shock, because most important thing we already discussed at the beginning of the lecture. And let's tell few words about the treatment of the shock. You understand that lots of factors can influence this prognosis for the patient, but most important is identification, and treatment the underlying cause. Maintain support with the oxygen, continuous cardiac monitoring, and monitoring of acid-base balance, water salt balance, use fluid resuscitation, crystalloids and colloids mostly, or blood products if we need it, and use pathogenetical method of treatment for the patient. Only such kind of approach can help and can prevent the death among the patient with the shock, which is unfortunately could be often. And as in summary, and to make some conclusion of today's lecture, I have to tell that to understand the shock, you must first understand the pathophysiology. But with pathophysiology of shock more or less clear, and once you understand the pathophysiology, then a recognition of signs and symptoms and treatments becomes intuitive. Thank you very much for your attention, and see you. Goodbye.